reduce the friction from inception to deployment so that production systems can be up and running on our infrastructure in the shortest time possible. It's also critical for businesses to understand the data management lifecycle and ensure that the cloud service provider handles the customer data in a safe, secure, and reliable manner. Now, at Google Cloud, we are explicit in our commitment to customers. You own your data, and we'll never use it for any purpose other than those necessary to fulfill our obligations. We provide protection from threats through a secure foundation, core infrastructure that is designed, built, and operated with security in mind. We provide customers with a constantly expanding area of controls they can use to help meet policy, regulatory, and business objectives. And lastly, we work to meet our compliance responsibilities and provide capabilities to make compliance easier for customer. We recognize the power of AI, and we want to do this in a safe, secure, and responsible way. Advances in AI will have transformative impacts in a wide range of fields, including healthcare, security, energy, transportation, and many others. Now, as we consider potential development and uses of AI technologies, we'll take and we make a point to take into account a broad range of social and economic factors and proceed where we see substantial benefits. Our AI principles that you see here are grounded around the ideas of fairness, privacy, safety, and accountability. Our AI principles outline 7 things that we believe AI should do. Things like avoiding bias, focusing on privacy, being accountable to people, upholding the highest standards of scientific excellence. Also, more importantly, we also call out 4 broad AI applications we will not pursue. Now, our technological innovation is guided by these principles and is rooted in the scientific method and a commitment to open inquiry, intellectual rigor, integrity, and collaboration. AI tools do have the potential to unlock new realms of scientific research and knowledge, and we continue to aspire to high standards of scientific excellence as we continue to evolve and progress our AI development. We believe the principles that are called out here are the right foundation for our company and for any company, and it's kind of the basis for our future development in AI. We understand that this area is dynamic and evolving. We approach our work with humility and a commitment and willingness to adapt our approach as we learn more over time. So I'd like to end with a quote from our CEO, Sundar Pichai. I mean, AI is the most profound technology that we're working on. It has the power to bring transformational change, and we have the responsibility to use this power for social good. We stay incredibly optimistic about the potential for AI and other advanced technologies to empower people and to widely benefit current and future generations. So with that, I'll hand it back to Rahul.
Thank you, Anil, for that very, very broad-ranging introduction and keynote to the session. And I love the quote with which you ended, because if you think about the current age that we're in, really that revolutionary technology that got us here was electricity. And electricity today powers absolutely everything that we do. It's completely responsible for the current state, or you can blame it for the current state of our civilization today. And in many ways, AI looks like it is going to be the electricity of the future, in the way that AI is driving through all of these, pretty much everything that we touch. So thank you. I'm going to move on now to the panel discussion. We've got a very interesting panel. We're going to range through a lot of different issues. To some extent, I'm going to try and have a discussion, but I'm going to encourage the panelists to, you say their piece in the beginning, and then maybe we'll have time for a few questions and then get in to some of the details later. So to kick things off, I started out saying that we're in a pandemic, and this pandemic has, it's sort of a black swan event. No one expected it. But now that we're in it, we've done some pretty remarkable things that perhaps we may never have done but for it. And our first speaker is Tavpritesh Sethi, and I'm going to ask him to really get into just this whole concept of the pandemic. How did we use AI for the pandemic? And what is it that we can learn from this? We're not yet out of it, but what is it that we can learn from this going forward? A quick introduction. Dr. Tavpritesh Sethi is from IIIT-Delhi, physician, scientist, innovator in the area of digital healthcare. His expertise is in building teams that bridge healthcare and computational sciences. And that's the beautiful thing about AI and data is really the power is in the intersection. You can be an expert at computer science, you can be an expert at medical science, but it is at the intersection that really the powerful work gets done. So can I turn it over to you, Tavpritesh, to kick us off? We are in a pandemic. Let's start in a pandemic, and from there, let's go through the rest of the panel. So if you have a presentation, why don't you share your screen and,
Sure.
and we can get
Thank you. Thank you, Rahul. I'll just share my screen and we'll get started from there. So I believe you can see the screen.
Yes, we can.
Thank you. So yeah, thank you for having me here. I'm going to talk about fighting pandemics with artificial intelligence. That's a tall claim, but I will try to show some of the things that have been happening, not just what we are doing, but also around the globe that can actually validate some of this claim as well. So before the CDC alerted and the WHO alerted, about 7 days before WHO and about 10 days before the CDC, there's a company, a startup, Blue Dot, based in Canada, which actually raised an alert that there may be a global pandemic that may be coming. The founder CEO of that company is Kamran Khan, based in Canada, and he is a physician scientist. The cool thing about the way they were able to do this was that they were able to combine non-traditional data sources, such as social media combined with flights data and what people were talking about on their flights, to really raise an alert about the pandemic. So that actually gives us the sort of a vision that we can have going forward of combining large-scale traditional as well as non-traditional data sources, combining surveillance data with some of these new types of data that are coming, and injecting domain expertise. Remember, he's a physician scientist, into the algorithms and being able to predict some of the really relevant challenges that we are tasked with. So this is not just a startup which actually just did the predictions, but it has been doing this for a while, publishing in top tier journals such as the Lancet. So they were also able to anticipate the international spread of Zika from Brazil, also H1N1, and they have been publishing their science, which is of top-notch quality. So which means that there is power in data, there is power in algorithms to be operated on global scale and raise alerts, surveillance alerts about these pandemics. So I'll come to what we have been doing about in this space, but I'll give a little bit of a background on what my background is. So I am a physician scientist. I did my MBBS and then moved on to computation, pursued a PhD in computational biology. And for the last 15 years or so, I've been in this space in the data for medicine and data for public health. So our venture into this space actually began with a project what we call Safe ICU project, Sepsis Advanced Forecasting Engine, which is based in AIIMS, New Delhi, where we essentially warehoused and built data solutions for predicting sepsis and outcomes such as shock in the ICU teams. So we actually automated the data collection from the ground up at AIIMS, and so far we have about 1.5 million hours of patient data at an every second interval that is collected at the pediatric ICU at AIIMS. So from there, we were able to build algorithms. We were able to talk and some of which is already in review beyond this study as well. Our work in public health actually started way before this. When I was a PhD student at CSIR GIB, and at that point of time, we were collaborating with Chest Research Foundation. And at that point of time, we were working on the data that was at that point of time the largest public health data available from India on a point prevalence basis. So this was a study conducted by the Chest Research Foundation Pune, where about 2 lakh patients visiting the OPDs of a doctor on a single day were profiled for their signs and symptoms. And we collected these, we analyzed these data, and we built AI algorithms, AI decision support on top of this, which actually showed that if we were able to increase the LPG penetrance into the districts of the country, we will probably decrease the prevalence of obstructive airway disease by almost a half. So those were the power. Again, here what we did was we combined publicly sources of information that were available publicly, such as the LPG consumption, along with these data that were collected on the nationwide scale. Again, combining these different data sources together. Coming to the COVID pandemic. So our work with the COVID pandemic started when we realized that, so it evolved with how the COVID pandemic actually evolved. So when it actually came into India, we thought that we should have a messaging system that can leverage the state-of-the-art AI and that can deliver the right information to the right people in the right format, in the right time, which means that nobody was actually reading those WHO guidelines. And how do we get these guidelines to the people where it matters the most? So we used AI to combine what the WHO guidelines said to what the news were saying. So to provide the right information. So it's sort of curbing the misinformation that is prevalent with any pandemic. Right now, I think this has been the largest misinfodemic so far. And then by using AI to match these sources of information, deliver it in a format that people would understand in their language, Hindi, in a bite-sized audio format. So this was the on-air engine that we used. Essentially, we used experts to also evaluate the similarity scores between what WHO and what the news articles were saying, and also incorporated user feedback. That this app is an Android app available on Google Play Store. Now it is actually not available for COVID because of the Google policies. It's available for TB right now, but it was available until about July and for COVID. And until then, we were able to incorporate user feedback as well. And we were able to show that with user feedback, our AI engine, which is the on-air, actually the performance of that increased. And it was able to provide more relevant articles as we went on forward in time. We were also able to capture more females in Hindi language, which was exactly kind of what we had started out with, that we want to reach out to this segment of the population where this information is probably not reaching out effectively. We also built natural language processing based tools, which is one of this is COVID NLP, again, openly available as a dashboard, which summarized the research that was happening at a fast pace and to provide that as a web application to distill that information. You can summarize articles. You can also query the engine, for example, for saying hydroxychloroquine plus pneumonia. So that's a kind of word algebra against state-of-the-art AI-based backends that are available. We built war room analytics. We were working in the core technical group of the Delhi government COVID response. So we built state-of-the-art projection architectures as well. I mean, projection systems that can project the need for different resources that need to be done. So, but now we don't care about projections anymore. But what that allowed to do us was to finally, this is my final piece that I'll be talking about. Can AI, as we move towards the phase of vaccine, can it help there as well? So the key point here is that the day vaccine comes out, there will not be enough. vaccine for every person on the globe. So the vaccine, the Serum Research Institute estimates that it'll be until 2024 that we will have enough number of doses of the vaccine to be available to everyone, which means that it is a limited resource, and we could use AI to plan the allocation of this resource. And that's what we did in this study. This is available as a preprint online on archive. It's currently under review in one of the venues. Essentially, what we are saying here is that um, just as just as AI learns to play
ambitious insurance program ever attempted anywhere in the world, the need to get digital medical records is really critical. Now, this is not a new problem. Very advanced countries in the world have tried, and I would say failed at actually trying to do this in an efficient way. Particularly since clinical care is really, depending on the time, high pressure. You've got to solve these things quickly, record this information quickly. So I'm going to turn to Randeep, who is the co-founder of Doxper. Randeep earned his bachelor's and master's degrees in mechanical engineering and a PhD in IT in 2006. But Randeep, as the co-founder of Doxper, has come up with something fairly unique and innovative in this. And Randeep, I'd invite you to discuss that and go into that in some detail. And obviously, I'm going to have a lot of questions for you after this, because it's a really interesting thing that you're working on.
Right. All right. Thanks, Rahul, and good afternoon, all. And thanks to the organizers for having me on the panel. Yeah. So let me just share the screen. Yeah. So I hope my screen is visible.
Yes,
Yeah.
it is. Thanks.
So, before I start, I wanted to set up the context and the background, which Anil has set the ball rolling. Like in healthcare informatics, there are different kinds of data available. Many of this data have already gone digital. Omics, for example, it's a digital data to start with. And of course, it is getting standardized. You have different file formats. Of course, there is ISO committees now who are trying to see, okay, let's standardize this data so that it will be easier to store, easier to mine, easier to kind of transform the data for various use cases, right? Another big vertical is imaging, which I think gets a lot of different modalities data, be it X-ray, CT, MRI, ultrasound. And of course, this was one of the first one to get standardized with the DICOM standard. So you can pretty much see this in lots of PAC systems from different vendors. Interoperability is very high. The third data set is pathology data, where you have all the labs data, your hemoglobin values, your HbA1c values, right? And of course, it's already standardized with the LOIN, and you have a very standardized way of reporting this, yeah. And of course, then the last part is EMR, EHRs, which is problematic. If you see the other data sets, many of them have already gone digital. Rest of them are going digital, or they have their own ecosystem. Now, EMR, EHRs, of course, the doctors need to put the data in, and which is turning out to be a big problem for many of these countries. So this is the problem we are attacking, and I'll yeah. So so you have to see in the context of where we are. Kind of, we cannot have just import the solution which is working elsewhere in the world and see, okay, this is how it's going to happen here. Now there are like more than 100 plus countries where the doctor-patient ratio is very adverse, and that's one reason why doctors are stuck with pen and paper, because it's very easy. And of course, EHRs, they have been designed with keyboards, with the tablets, with a lot of things, even speech to text. But doctors, they have practiced like for so many years with pen and paper. Now it's very difficult to change their behavior, and they feel very comfortable. It's gone to their subconscious that you give me a pen and paper and I can write for the patient whatever the observations and the prescription I have to do, right? Now, so, and of course, there is an existing clinical workflow which doctors follow, and it has almost become a habit. So you need to kind of fit right into the current clinical workflow so that there is no disturbance. Yeah. So our vision is that Doxper to be used wherever pen touches the paper, so that we can also digitize the data and put it into the ecosystem, right? Now, here are the existing pain points. You know, okay, if you are typing in front of the patient feels the doctor is not seeing me, but the computer more. And of course, it leads to more consultation time. So many places it happens, okay, the doctor kind of notes it in, let's say, a paper or something. And when the patient goes out, he's kind of dictating this to the computer or typing it in full. Or you might have read articles that the doctors are spending like maybe 2 hours of their personal time to type all the data in EMR, EHRs, right? And also, many of the doctors who are our good customers are saying, unless the pen is in my hand, I cannot think, right? So this is kind of a more of a behavioral problem, and the thing which they have been doing for many years, we can't expect them to change overnight. Yeah. Now, of course, EMR, even in the US, where the number of EMR players are, let's say, very limited. So top three like Epic, Cerner, or Allscripts. So they don't even have interoperability among themselves. And many of the hospitals prefer that the data stays on premise in their servers. And of course, this is one of the industries which is heavily regulated. There are lots of privacy issues. Yeah. And of course, lack of interoperability standards, which I mentioned. And of course, once you force the doctors to type, the kind of observations, the kind of different notings which the doctor wanted to do, I mean, he will not do it because this is too much work now. So yeah, so there are gaps in digitization, and of course, you don't get the data quality which you want, and this leads to kind of you cannot do kind of analytics with statistical power. And if this was there, so this can help like policymakers, researchers, even the clinical decision support engines. A lot of data which can go into that, right? Yeah. So here is what our offering is. So we use digital pen and paper. So those of who have heard of LiveScribe or Anoto or Neo Smart Pen. So these digital pens have been in existence for many years now. So what we have done is taken this as a hardware, and this becomes a new keyboard for the doctor. So their workflow isn't changed a bit. So they are doing whatever they are doing currently now. Yeah. And they write on the templates provided, and whatever they are writing, we sync it with Bluetooth on a device. This goes to the backend server. We analyze it and send the data back, and even make an ecosystem within a hospital, for example. Yeah. So this like, I mean, those who have implemented EMRs, usually it takes maybe many months to a couple of years to get the new EMR stabilized in a hospital. Our solution takes just 4 to 6 weeks to get stabilized, and we can digitize the complete hospital, and the compliance is very good, and all the doctors use the system. Yeah. So this is the templates I was alluding to, right? So you can see it as a surface or an interface, which probably you will design on a browser or on a tablet screen. What we have done is we designed this on a paper, and we get the feedback of the doctor who's going to be using this. And if they feel, okay, I want to change few things here and there, so we incorporate their suggestion, and now you have a buy-in from the doctors. And usually these changes reflect back into the system within 24 hours. So it's that quick turnaround time. And at the back end, so we have our own proprietary handwriting recognition engine. So on the top left, you see this is just a dummy data. So if you write unstructured format data like this, so first we do segmentation. Of course, at the back end, all of these segments are labeled. So we have like a few million data points which are labeled according to the specialty, according to the drug dictionary, according to the lab dictionaries. Yeah. And in order to cut down the labeling time, we do shape matching. So you can imagine doctor writing a lot of these medicines again and again for those patients. They need to be labeled only once. That's the engine we have built. And our accuracy on structured data, on numbers, on the patient's name is very high. And we are still working on the unstructured accuracy, which is about 70 to 75% right now. And of course, we also have a medical transcription team, which can cover the gaps which are left by the deep learning engines. On the bottom, you see the kind of numbers we have. So there are 4 million unique patients with us. And before COVID hit, we were doing around 600,000 monthly prescriptions. These are longitudinal data. And we have about 4,000 doctors, 2,000 doctors, individual clinics, and 2,000 doctors in hospital who are using it. And even in tier 1, tier 2 towns, 15 cities, we have our doctor base. Yeah. So this is in a nutshell how the data comes together. So there are 4 parts to it. So data input, of course, rather than use a keyboard, we use digital pen and paper. No behavior change for the doctors. Tends to be excellent compliant. order sets where you kind of make it specialty specific templates, and these are designed with the HODs of the hospital or the senior key opinion leaders. So there is a buy-in from the doctors. There is an ecosystem play. That's the beauty of the digital data. So we have certain rule engine which can generate triggers based upon what the doctor is writing. So it could be a follow-up compliance, it could be the patient adherence, or labs pharmacy or scans department automation. And of course, the long-term play is we want to build a real-world evidence engine based upon that. Should be able to find patient cohorts. We can do diseases surveillance on this data. Of course, this is all anonymized and aggregated data. Yeah. So I'll stop here, and yeah, I think my time is over. Yeah, thank you.
Thanks, Randeep. Before you go, this is actually tremendously fascinating because I know how difficult it is to get doctors to key in EMRs. It's one of those things where they would try and avoid it as far as possible. But if you give them a pen and paper, as opposed to a keyboard and a computer, or even a tablet with a touchscreen stylus, pen and paper is so much easier for us to use. But I think the question I really had was, how will this work? When we go out into rural India, or in places where I noticed that it is Bluetooth, so it actually goes to a proximate device, and so you're not worried about connectivity.
Yes.
But I'm just trying to explore a little more how this would work in the real Indian setting.
Yes, sure. So let's say rural, there are infrastructure challenges. We are assuming there is no internet, or there's an intermittent internet, there is no electricity or very patchy electricity, right? So we had done a project with the Biocon Foundation. So instead of the pen being used by the doctors, so this was in ASHA workers' hands. So this was kind of surveying a population for early signs of oral cancer, right? So we had these 25 ASHA workers. So they had pen in each of their hand. Of course, the pen can be charged just like your mobile phone. It has a USB connector. Yeah. So once you have your power bank, you can charge the pen. And each pen individually can store up to 1,000 papers data, right? So the workflow was these ASHA workers would like go from door to door screening, and we even printed those papers in Kannada language. So they could ask these questions and write there in the language. And of course, since each and every bit of the paper is mapped at the back end, so we know what answers are according to which questions, right? So we were able to screen about 5,000 subjects in 3 months' time, and we took about another 3 weeks to analyze the data. So out of those 5,000 subjects screened, so we gave them a list of 400 people saying, okay, these guys are showing early signs of oral cancer. Now they need to be brought to the center and done like more advanced surveillance. So, I mean, they were very happy with the results. And yeah, so the answer to your question is yes. I mean, this is a very appropriate technology for countries such as ours, which has these infrastructure challenges, and it's just pen and paper. So even if the pen is not charged, you at least have a paper copy. And in the end, somebody can see that paper and type it out. So you don't lose any data, right? And of course, we took a conscious decision. So even let's say in times of emergency, let's say your system is down, your internet is down, right? So what the doctor will do, he will say, okay, let me just pick pen and paper and write it, right? So in our solution, the plan B is actually built into plan A. So there is no disturbance in the clinical workflows, right? Yeah.
No, thank you very much for that. Fascinating to see how we're using big tech with really old, simple tech. I'm going to turn now to our next speaker, Manish Gupta. And before I introduce Manish, really, when we spoke and discussed what Manish was going to say, he's going to deal with preventative care. And we all know from when we were children that prevention is better than cure. And so if we can use all this this power of data that we have to actually prevent the disease from happening before it actually does happen, the advantages are enormous. Manish is a director with Google Research. Before this, he was a co-founder with VideoKen, which is a video technology startup. and he is the Infosys Foundation Chair at IIIT Bangalore. Manish, in his introduction, I think Anil briefly touched upon some of the things that Google is doing. And quite frankly, Google is doing some really path-breaking and quite remarkable things when it comes to picking up signs of illness before they actually occur. So can I ask you to take us through some of that? And obviously, I've got a ton of questions as well, but just leave it to you for your opening remarks, and then we can get into that.
Thanks, Rahul. So I'm sharing my screen. Hope you're able to see it.
Yes, thanks.
Okay, so so you kind of really used the line, right, that I was going to lead in with, right? Prevention is better than cure. And this is an area where I feel AI can really help make a difference. I mean, if we look at the healthcare system itself, right, it is built in all these different tiers. And the most expensive tier is the ICU, which is one of the doctors famously said, right, is one of the most expensive places to stay overnight, more expensive than a 5-star hotel in a fancy location. So the point he was making was that, look, if you can take care of the person before they need to enter the ICU, that is so much better, both in terms of cost as well as outcome for them. So taking this argument kind of to different tiers, you can say, look, if you can take care of people at the primary healthcare center, that's better than having to take them to a super specialty hospital. And continuing that argument, I mean, my view is that the real action in healthcare is going to be before you get to the hospital. When we are living our normal lives at home and at work, we are going to be instrumented. There are going to be these mobile phones, wearables, potentially there could be cameras and so on, right, through which we can be monitored. Our health parameters can be monitored, and AI can be applied to make those predictions about the risk factors that we have and suggest timely interventions. So let me start with just provide two quick examples. And in fact, the third example will be provided by Dr. Aparna, who's been a wonderful collaborator with us on our AI for Social Good program. So the first example I will use is diabetic retinopathy, which is, again, one of the leading growing causes of blindness. And potentially any of the over 400 million people in the world who are affected by diabetes, they are potentially at a risk for this condition and therefore blindness. Now, early regular screening is the key to preventing blindness. And what happens in a country like ours is there's a shortage of pretty much, you look at general physicians, there's a shortage of general physicians. You take any specialty, there's a shortage of doctors with that specialty. So what ends up happening is, in India, 45% of the patients end up having this vision loss before they're ever diagnosed with the condition. And the way they would diagnose it is to start with this retinal fundus image, and the doctors look for signs of hemorrhage. And then they grade this particular case on a 5-point scale. The lowest being no diabetic retinopathy, and the 5 being proliferative diabetic retinopathy. So what our team at Google Research did, and this work got started by, again, my colleague Varun Gulshan, who in fact had moved to Google, to basically India before Google Research even existed in India. He started doing this work from India. And essentially what they did was they took the deep neural networks that had been developed at Google, and likewise there have been other research groups applying these technologies for the well-known task of image classification, right? When you are able to distinguish whether it's an image of a cat or a dog, they basically took that same architecture and extended it to be able to process these images, which had been, again, labeled by doctors, and started doing this automatic grading. Again, initial results, there were various issues. So they kept improving their algorithms until, again, after a few years, they reached a level of accuracy comparable to a general ophthalmologist. So again, I mean, on course to doing that, they again improved the resolution, used various like hyperparameter tuning and so on. But what they achieved was initially results comparable to these ophthalmologists, and they published that work in the Journal of American Medical Association. And in fact, the medical community again really recognized this as a kind of a very significant contribution. And sorry, I think maybe there may be some issue with, sorry. Yeah, hope you can see the slide more clearly. So this paper was earlier this year rated amongst the 10 best JAMA papers of the last decade by this journal. And then this team went to improve these results even further. And one of the things they did was, there were many cases where the ophthalmologists themselves did not agree on what the finding should be. I mean, there are always these complicated cases where doctors have a difference of opinion. And in that case, again, the team used this adjudication process where they went to these retinal specialists and asked them to independently rate those images. And again, I mean, if they came to a consensus opinion, that was taken as ground truth. If they didn't have a consensus opinion, they were asked to kind of talk to each other and come to a consensus opinion. And that was taken as ground truth. And with that, again, this team was able to achieve results that were comparable to the retinal specialists. So that was a follow-on piece of work. And now we are again in the process of working with our partners in India in deploying this solution in the real world. So I will also mention that, I mean, on one hand, I would say, yes, these advances are very, very impressive. On the other hand, I would also provide a caution that there are still outstanding issues associated with AI algorithms that need to be dealt with when we think about deployment in the real world. And one of those issues is the confidence of these algorithms, because just like humans make mistakes, algorithms will also make mistakes. And one particular difference, which is an active area of research at Google Research and by other researchers as well, is how to calibrate these deep learning models better. Because what happens is when humans are faced with a complicated situation, right? Doctors see a complicated case, they know it's a complicated case, right? And they know that, yes, I should maybe seek a second opinion from my colleague. Whereas a deep learning algorithm can sometimes just make kind of wrong predictions in a very, very confident manner. So there are those issues that need to be dealt with, and those are subjects of active work. So I believe I'm out of time. I'll maybe just take a minute to talk about another piece of work that we are doing, where again, I mean, this is based on our belief that the real action in healthcare is going to be at home and at work when we are living our normal lives. So again, the basic idea is through these sensors that are available in things like mobile phones, can you monitor again and apply AI itself to the output of these sensors and infer a whole bunch of things related to body vitals, activities, state of mind of the individual, environment, and so on, and start analyzing these signals to come up with risk factors for individuals, and then further by applying AI, again, come up with suggested interventions and engage the person again, not just notify them, engage them in a dialogue to go for that intervention. And the specific case that we are applying it to right now is cardiovascular disease, which is one of the major killers of humans across the planet. And in India, an added kind of a sad aspect is that it is estimated that roughly 80% of the people who are suffering a heart attack or a stroke are actually not aware that they are suffering from, that they are at this risk of these adverse events. So, so our cardiologist colleagues, collaborators, they tell us, Dr. Santosh from JIPMER, and we are also collaborating with Tav from IIIT-Delhi. They tell us that, look, there's a potential to add 10 to 15 years of healthy life to people if you can kind of only convince them to go for these lifestyle modifications. And again, in a longer talk, I talk about how you deal with all the data privacy concerns, because when you're taking all this data from mobiles, this is very sensitive data for an individual. So there are technologies that I won't talk about here, like federated learning and so on, that allow you to do some of this AI apply some of these AI techniques in a very privacy preserving manner. But let me just kind of stop with this kind of a view that what we are doing here is, again, just one example, right, of how through sensing what people are doing, what their body vitals are, and so on, you can really start to provide them with helpful tips about early interventions. And my belief is this kind of a approach can actually be applied to many, many other diseases and ultimately help people live healthier lives. So let me stop here. And again, I can take some questions.
Yes. No, thanks, Manish. I'm really glad you brought up this last point, which is sort of in and around just the devices that we have on us, because today we're generating so much data. You mentioned a mobile phone, but equally we've got smart watches, things that are continuously collecting data about us. And previously, when we went to doctors, we actually would go to the doctor and then they would take the ECG of us. But if we can go to the doctor and show us our ECG over the last 5 days, including the time when we actually had the heart arrhythmia or something like that, how much more powerful it would be. So, I guess the question for you is, are we going to see a fundamental shift in the way in which medicine is done? Because right now we're doing medicine sort of post facto. We're trying to diagnose from something that a patient tells us. But in the future, can we actually do, in a sense, real-time medicine, because we will get that sort of data?
I very much believe so. And back to your scenario that you painted, it's not just that you go to the doctor. Potentially, the app running on your mobile device could alert you that, look, we are seeing these signs of whatever, let's say arrhythmia, and maybe it's time, right, for you to go and consult your doctor. So absolutely, I believe this is really the key to ultimately improving the quality of healthcare, because everybody wants the quality of healthcare to be improved. At the same time, pretty much every country on the planet is also struggling with the very high cost of healthcare. So this proactive approach can actually lower the cost while improving quality. And in a country like India, where we have such a severe shortage of doctors, this can really kind of help you, right, before you kind of have that need to go and consult that doctor. And of course, arm that doctor with a wealth of information, right, so that they are able to treat you in a much better, much more effective manner.
No, fantastic. And I think Anil mentioned that AI is like electricity was in the previous generation. It really feels like that we've got this new superpower with which we can actually change the way in which we do medicine. Dr. Hegde is also on the panel, and you mentioned that Dr. Hegde was going to be your the third use case that you were talking about. So I actually, I know Dr. Hegde's got a full presentation and just take us through the service. But I did want to speak to you just a little bit on a sort of a high principles level about the work that you're doing and how exactly you thought to graduate from someone who is actually a physician to getting into this data-driven space, and now as the founder of Armman, doing so much work on the field. How exactly did that happen? And maybe you can sort of briefly tell us about what Armman is doing, But I leave it. Don't put your presentation on till later, so we can actually see it, see that in full.
Absolutely. Yeah. So thank you so much for having me here, and we've had a wonderful collaboration with Google, on using AI in our work. So I think I'm the only panelist who is a practicing doctor. I mean, I'm a urogynecologist practicing. I'm a professor at Kama Hospital also, and have centers in Delhi and Mumbai. And I founded Armman based upon my experiences during residency. When I was doing my OBGYN fellowship training in Mumbai, I saw extremely closely how pervasive systemic problems led to loss of lives that are completely preventable. If you look at the real world issue, it's horrific. I mean, there is a lot of indignity that women and children have to face just for simple things that could have been easily prevented. And I saw that daily. And, realized very early on that if I want to really prevent, in Sion Hospital, where I did my residency, you used to have 70% high-risk women coming and high-risk children coming. And, if you really want to prevent that from happening, it is very obvious to me that you have to go to the community and work in the community to ensure that they do not end up with these risk factors that are so not taken care of, that's too late by the time they come. And given India's numbers, and my presentation, I'm going to show you the numbers of India, right? India's numbers are horrific, right? India accounts for 11% of mortality of the mothers annually, globally. And if you look at even children, I mean, the mortality rates are one of the highest in the world. So given the scale of India's problems, it was very obvious that one has to design for scale from day one. Right. I mean, traditional models, if you look at when, 2008 is when I founded Armman, and traditional models depended on, either women coming to hospitals to access care or, health workers going home to home. But in fact, it's extremely resource intensive, right? I mean, I have sat in antenatal clinics where there are 200 patients waiting outside. I've had hardly a minute with a patient, right? And then, imagine you can't even have a second to counsel them. And then they don't come back. It's extremely apathetic. Coming back only, maybe dying in labor, or the children coming back malnourished. And over again, I would see that, I had seen her in third month and she never came back. So, I was racked with guilt, whether I had really counseled her enough, told her enough of the danger signs, etc. Same thing with, health worker training. There was not enough, facilities to be able to train them enough to be able to kind of, pick up risk factors in time. So it was obvious that you would design for scale from day one. And then mobile phone came to India suddenly. And when the mobile phone came to India, it's within 2 years, it spread through the country. And it is obvious that, it is an easy to use technology. It is not technology that I have to invest in. There's no new device I'm creating. It's something that the women automatically had access to within their family. And also, they were going to upgrade themselves. I mean, when I saw the iPhone in the United States, I realized within no time, in the next 5-6 years, you're going to have cheaper smartphones coming to India. And it's already happening. 30% of ASHA workers have smartphones. So it is easy to use technology. It helps you design scalable solutions. Also, it helps to keep it resource intensive. You don't need to have so many hands on the ground, right? But it was obvious that you have to use a tech plus touch approach. Because technology alone does not work. You have to have a touch point. You have to have the health worker introducing the program to the woman, or you have to have somebody in the hospital introducing the program and be available to give feedback, or you have to have a call center. So the woman has a touch point. But because you have technology enabling the program, the number of touch points from human resources are much less. So the program becomes extremely cost effective, right? So that's one pillar of our programs, tech plus touch, right? Second very important pillar was, do not create your parallel infrastructure. And the government of India has a wonderful network of, health workers on the ground, the public health hospitals on the ground. So why not use that infrastructure and also use the infrastructure of community NGOs on the ground? So leverage that, not to create your own parallel network and apply technology to it. That's why we work through, partnerships. We have partnerships with almost 97 hospitals and 40 NGO partners and the government of India, right? So partnership model. Lastly, evidence-based approach. So everything Armman does is proven. Every program of ours starts off as an RCT, right? So I'm going to show you mMitra program in my PowerPoint presentation later on. And clearly, every aspect of it has been proven using an RCT or a pre-post intervention study before we apply it on the ground. So these are the pillars that we.
I think let's leave the details on mMitra for your presentation, but just very quickly to touch on COVID. And I think the power of having a lot of these platforms, I think Tavpritesh mentioned this earlier, is if you're already in the space, it allows you a unique platform to actually pivot when it's really needed. So can you maybe spend 2 or 3 minutes to talk on how you pivoted during COVID and what really happened?
as I'm going to show in our presentation, we have two basic programs using technology, right? On the one hand, we have a program that sends voice calls to women through pregnancy and infancy weekly, right? So we have this whole tech platform sending voice information through phone calls to women. It's almost 16 states in India currently, right? So it's 18 million women getting the information weekly. And on the other hand, we are collaborating with the government of India to manage the mobile academy program, that is the ASHA training program using mHealth. And that has reached across to 170,000 health workers, right? So we already had that network in place. You know, huge tech platform is the largest in the world, both Kilkari, which is our government of India program for giving information, and the mobile academy. So we already had that tech platform in place. Secondly, we already had a network in place. I already told you that we had this, partnership ongoing with hospitals on the field and NGOs. So when COVID struck, suddenly overnight everything stopped, right? I mean, the hospitals closed down. There was lockdown. Hospitals became COVID centers, and the slums where the underprivileged live in Mumbai and Delhi were the most affected, and there were containment zones, and there was no public transport. Now, pregnancy and infancy cannot wait for a lockdown. If you need an ultrasound, you need an ultrasound immediately. If you you're bleeding, you have to immediately go and take care. Unfortunately, there was no care available easily. So we were getting these distress calls to our call center, from women in the field. So overnight, because we had this platform in place, we have a call center which is manned by regular counselors, right? So overnight, we created a virtual clinic. So within 3 days, we had a virtual clinic on board where we had an antenatal clinic in the morning time and a pediatric clinic in the afternoon time, manned by 60 doctors. And we were getting calls from all over the country. And, we had a 2-tier system where, our first layer was our own staff handling logistic issues. Around 50,000 women we've helped with logistic issues, like where do you go? How to get an ambulance, right? I mean, where is an ultrasound available? So all these logistic issues. And then the next layer was the medical doctor on the field. Who take a call for any medical queries. So, oftentimes you can give home remedies, right? Other times you validate the, emergency and you say, okay, you really need to go now. And how do you go, right? So in that way, almost 50,000 women we've helped get care during pregnancy and infancy. The other thing we've done is that we collaborated with the government of India. I told you we have this whole health worker platform through which we train ASHA workers, right? So we leveraged that during COVID. So when government needed to send information regarding, say, for example, the new health insurance scheme the government of India has, for rural doctors, ASHA workers, and ANMs with regards to COVID, right? Second point was how to deal with stigma or how to take care of health after the lockdown ended. So all of this information we could send overnight to the ASHAs and ANMs and rural doctors. We sent to around 800,000 health officials through the country using our platform through SMSs or voice calls. And lastly, what we did was, pregnancy is considered a very vulnerable period for COVID, right? And what we did was, we already have, in Mumbai, for example, we have 3 lakh women actively getting M-Mitra service. So we had this active, live database with all their phone numbers validated, with them having access to a call center, etc. Right? So we send COVID-related information, and we kept every 6 weeks, we kept on kind of updating the information so that they had live knowledge about how to take care of themselves and where to access care. So we have
so fabulous. I mean, this is just the power of actually having an infrastructure that's built out using the data platforms that we have. That gives us the ability to pivot at the right time. Dr. Hegde, I'm going to wait for your presentation after this, but I do want to, while we're still on this whole concept of public health, I want to turn to Krishnan Dharmarajan, because I think some of the challenges with doing public health is really doing public health in sort of the challenging circumstances in India, rural India, particularly in the deep hinterland. We actually don't have the kinds of infrastructure that other countries in the world which have rolled out these sort of data-driven public health services. We just don't have the infrastructure to be able to roll that out. And so how do we roll out these technologies in challenging circumstances, particularly if we're going to rely on data? So, just to make a quick introduction of Krishnan Dharmarajan, Executive Director of the Center of Digital Financial Inclusion, CDFI, and worked with and pioneered several digital initiatives with a particular emphasis on social impact. Krishnan, I think when you and I spoke earlier, you had some real live examples of rolling these sorts of platforms out with state governments in extremely challenging circumstances. I think you were talking about when we spoke, when you go to Shillong, your phone connection cuts halfway through. How are you going to deliver a reliable data-based health solution under these circumstances?
Thank you so much, Rahul. It's a pleasure to be here with everyone. And of course, amongst the people like Google, we are a small academic center and academic institute. So we are also trying in our own way to see how tech can be used and most appropriate manner. Apart from the kind of places we know. For example, where we did our pilot was about 8 hours of drive from Shillong through the hills. And mobile phones rarely work, and there are issues. And yet, what we did was put in place a whole system driven purely by mobile and cloud in a short time. And I loved the word pivot that was used, because we pivoted it fantastically for COVID. So while we were actually tracking expectant mothers and all their health conditions across the state, in a situation where the chief minister on his iPad can drill down to every last expectant mother and their entire risk factors and the treatments and what is happening, we were able to pivot that for COVID now. So all hospitals are network, every diagnosis, every treatment in the state is network, every migrant coming in, we know his symptoms, where is he coming, where is he going. Every health worker's visit to the home is all digitally tracked and on a platform, which is actually run and used by the government officials. So it's not an external person. So what we feel is a sense of possibility in not just bringing technology externally and doing it, but actually embedding it inside the way the government works, inside the way they will do their normal work. This is not something external. They will want it and they won't be able to do without it, because it's so low cost, it's so scalable. We rolled out our COVID system across the state in 1 month. 1 month, all hospitals network, every treatment track, every migrant track, IVR to every migrant, 14-day tracking in the quarantine period, all symptoms flowing in. So the whole thing is possible in a short time. So what we are trying to see is, can we use tech, low-cost tech, even in remote areas, low resource settings, and yet achieve the kind of impact that we do. So on the AI front, what we felt, what is our approach is, which I'll try to explain in 2-3 slides. If you're able to see.
Yes, your slides are up.
Yeah. So if you see, when we look at AI and our approach to it, it is embedded in the larger concept that we are driving is using data and analytics and potentially AI across sectors. So it is not one part of the government. It is not healthcare where there's an island of excellence or some maternal health, which is a smaller island within that where we do amazing things. It is the way the entire government has to function, because finally all this is delivered through public officials on the ground. They have to look at the world differently. Healthcare will be one thing. So if there is a district collector, he would look at a dashboard for healthcare. He will quickly go into a similar dashboard for rural development. He will go into the same thing to look at the farmers. So everything comes together through a new approach to governance, and healthcare being one part of it, right? So when we were looking at the way we have to plan AI, so when we start with looking at data itself, we start planning on how the AI would do, what we would do with AI, so that we plan early on. So first thing for us to understand is to understand what is actually happening. Do we have the data? And we heard in one of the earlier presentations, somebody said that, some of the data is not digital. I will not say some of the data is not digital. Most of the data is not digital, and most with the capital M, O, S, and T. So it's not digital at all. So your first approach to even start doing AI is to get it in a form which is digital, where you can start doing something with the data. So how do you do that? And then what's it that drives those outcomes from this data? Where to drive interventions based on what we can predict about those outcomes, and what are the long-term initiatives that can be taken to improve the overall system. So the first thing that we did, and we have put in place, is look at patterns, descriptive analysis, leaders, laggards, dashboards across key areas in the health space. So we started with, among other sectors, we started looking at health, and then looking at mother and child, the entire delivery, how it happens, and post-delivery, tracking that across the state. Again, it's at scale. It is not in a small village or a block. It's statewide and driven from the top with all district collectors on board. So that's the way it's happening. So getting the data first, what do you do with the data? And then looking at correlations and the factors that can influence the outcomes, the kind of outcomes that you have. What are those correlations? What are those factors? And here we have started using AI. We've come to some predictions. We're able to predict under certain things will happen because we have the data. And then what are the specific interventions that can be done? For example, if we know that in this kind of situations, this is what we need to, for example, we know that these are the places where people have to travel longer distances for the delivery. So can we probably get the roads right? Can we have an incentive or can we have subsidized transport for the women to travel to the PHCs? We did that. So the government took a policy decision based on the kind of distances women were traveling, that they would give a reduced cost for them to travel to the PHCs. To actually, do we need to invest in a new PHC in some areas where the travel is more? So all that flows automatically through the data, which I will show you subsequently. And what are the specific interventions that can be driven? And going forward, what are the long-term things that can be done? So when you start doing these interventions will start producing an impact. So you will know what are those interventions that are producing more impact. So do we have a ROI on that? For example, if you want a specific outcome, is it that if I launch an awareness campaign that can deliver better result compared to setting up a new PHC there or maybe constructing a road? So there are multiple avenues always where the government can spend money to improve outcomes. So can there be a feedback loop on the kind of interventions that have happened, on the kind of health outcomes that have been produced by those interventions, so that we know which is the one that works better? So there, from immediate action, we have AI also driving policy. So we should be able to predict even what are those things which can drive better outcomes. So that comes in a state of maturity. So what we are looking at is that we need to work with data, we need to work with models over a length of time, maybe 4 or 5 years for the last stage to be reached, so that we get the full potential. But in order to do stage 4, we need to start planning right now on stage 1. Because if you want some data point in stage 4, you won't get it. It has to be there and it has to be collected by you on stage 1 and 2. So we have now running it for the past 9 months or so. We have further tweaked the entire data collection process, made it wider, deeper, so that we get now more data sets, so that we are able to see. So that's a feedback loop on the actual data collection that we are doing. So what is it that we need to have in place to get better and better modeling, better predictions, and better AI? So some of the broad principles we felt, which we should have in place, is that the data collection itself has to be continuous. It cannot be one-off. So the whole process of governance has to involve getting data digitally and working on that data. That should be the sole vehicle on which the government works from top down. And it needs to be substantial. We need to go beyond pilots, collect it in substantial volumes, being able to scale that and work with the people on the ground to be able to do that. And need to have depth about it. So it's not just health, it's also the surrounding conditions. What are the demographics? What are the economic and social status of the people involved? They all have an impact. And we have done modeling to find out, yes, it is not just the specific health part of it. It is also probably the kind of conditions available in that village that also influences the health of the person. So get more data in, the wider kind of data that we get in for driving the models, the better it is. So that is why it pays to have the health system embedded in a larger data governance framework, so that health is part of the larger way the government moves in the entire area of governance, right? Then, of course, the other issues of privacy, security, storage, all that is important. And what is essential is a deep collaboration between the health institutions, the government, and organizations that are committed to social good. We need to come together for all of this to happen. These we feel are some key principles we have worked on. And what we need to focus is on low resource settings. How do we digitize what is happening? How do you understand what is happening, as we said? What drives outcomes? And also look at what long-term decision support systems can be put in place. For example, today, we have a position where every birth, every childbirth delivery across the state we track, just click on that and you get all the details of the person. This is available at the highest level. So it can float the iPad, the chief minister, right at the top. He can have full control. He has full control today on all of this. He has full data on this. So this is the beginning. Unless you have a foundation of data on which to drive, you cannot build any AI model. So when we start getting more and more of this, when we start also understanding what the data can do, So it's not just driving a blind AI model, you also have causal correlations between one factor and the other, so that you develop more meaningful models. So it's very important to get the maturity in dealing with data and working with data at scale. Right? And of course, automatic plots like this we have, which come automatically on the system, and on each of the districts in the state, how much distance is the woman traveling to go for delivery. And this gets updated continuously on the system, so that we know at any point of time, the distribution of women, the distance they have to travel for institutional deliveries, and what can be done better about that. So we felt when we started working on this, just hold on. So the first thing we started working on was to work on institutional deliveries. So this across the whole state, the state government was able to take it up based on this analytics-driven model from about below 50% to up to 70 to 80% now. And then going forward, looking at other areas on which outcomes can be achieved. So I'm not going to go into depth into this, just to show you that there are multiple things that we're doing here. One of the things that we're doing is automated alerts from the system. So when we have data, we actually don't just wait for the officials to go in and find out what's going on. We have so many pre-configured alerts. So based on a certain set of conditions, designated officials get alerted. So in case there's a low birth weight, preterm babies are going to be born today, so they are all alert in that whole area. We have high-risk identified women whose expected date of delivery in the next 7 days. These automated. So these are all automated alerts that go from the system automatically. You see on the right-hand side. So there is something which the people can work on proactively on a data-driven governance around health, and there are others which are part of the alerts which go, proactively, which go from the system without even the health officials knowing about it. And all these alerts and stuff, once the AI model gets more refined, AI itself can generate some of those alerts. So we know these are the cases under these circumstances that are likely to be risks in the point of delivery, right? So we have this kind of a framework which is in place. I'll go quickly in the interest of time. So what are the uses that we are working on? Predicting high-risk deliveries. We are already working with the state and modeling this. We have developed 2 or 3 models where we're able to predict what are the high-risk deliveries based on a range of conditions. And this kind of modeling will be very area-specific, very state-specific, very condition-specific. So we cannot generalize it anywhere. You have to work with the data in that context, in the area, to find out what are those parameters which are driving the risk, and the model will throw it up. Then also, next step, we have just started to build on the model for predicting preterm babies. So can we predict the circumstances under which preterm babies will be born? Because worldwide studies show about 12 to 15% of the babies are preterm. And we also have, we talked about diabetic retinopathy. There is another special form of retinopathy called the retinopathy that occurs in premature babies. If we are seeing 10 to 15, this 12 to 15% are preterm babies, and 10 to 15% who could be at risk because of the risk of blindness. So it actually makes a lot of sense for us to predict those cases where there will be preterm babies, so that we can have the necessary steps taken to see that they are checked for any signs of retinopathy early on. Right. So this is another area where we're trying to see, can we predict those areas where the preterm babies will be born, so that we can move in early there. And of course, the propensity to deliver at home. So we found a very direct correlation, very strong correlation between home delivery and maternal mortality. So can we move in quickly on those areas, on those cases where there's a propensity to deliver more at home, so that we can move them to starting to deliver in institutions. So, and when you know that there is a propensity, then you can actually take steps to provide the right mode of transportation for the mother to go and deliver at the institution. And we have found a range of factors that can influence this propensity. It could be social belief, customs, the kind of family support that's required. So it is not just clinical. There's a whole lot of factors which go in as inputs to that model, which will be able to predict in which cases will she deliver at home, in which cases she's likely to go to the institution, all of that. Okay. So just a broad look at it. If you look at the wide variety of parameters that we actually work on, right from pure clinical set of parameters on every mother relating to tetanus immunization, whether she has taken IFA tablets, whether calcium tablets are taken, the regularity of consumption, the order of pregnancy, all of those real health conditions, to actual operational conditions around the health area, whether the ASHA worker is visiting her, whether she has been counseled, whether she has been given the pamphlets for immunization, whether she's aware of the various government schemes, whether she's enrolled in them, whether the ambulance driver has been familiarized with the family, has she been given the phone number of the ambulance driver? So all of these are potential parameters that will drive the riskiness of delivery. And so each one of them we capture 100% basis across the state. And this is important for us to start getting some rich data to drive the AI model. That's very critical for us. And of course, over and above the clinical part of it, and the surrounding, the health infrastructure and the people around it, are other things like, if we can get, because in many cases, we do have the data, but it can be part of a larger program where you could even have information on whether there's a toilet at home, whether the woman stays in a pakka house, whether she has a mobile phone, sleeping fan, whether she has a mattress to sleep on. So we never know what are the different environmental conditions which actually influence the health. And when we have data, and we have data coming from multiple sources, all of them can be rich information for us to drive our models. And of course, at the village level, her whole environment, right from a house, the village, how developed is that village where she's living, whether there's an Anganwadi there, whether she has access to mobiles, drinking water facilities there. So many of these factors have a play in deciding, in able to predict any kind of a risk around the health area. And when we build a model, all of these inputs need to come in. We have found some correlation, including correlations between the riskiness delivery from who is accompanying the woman to the for the delivery. Even there are strong correlations there also. So these are all interesting things that are coming with the data, and it could be very different for every state could have its own story. But I'm just trying to highlight that we need to look at this whole thing holistically when we develop an AI model. What are all the different factors that go into it? And this is a very typical Indian remote rural setting, where there are barely roads and barely connected. So this is the actual place where women are getting born, where we need to bring down the maternal mortality and child mortality. So just to give a broad idea on the kind of parameters that could be involved, I will just stop share here and quickly just show you one screen if that is possible.
We'll have to do it quickly, Krishnan, because this is fascinating. I wish we had more time to actually see some of these in more detail.
Yeah. So let me see if that.
So while you're rolling it up, I actually, okay, there it is. It's great. Yeah.
I do not coming up at all. I think, yeah.
We actually had a number of questions that have come in. I'm afraid I won't have the opportunity to ask all of them because there literally are a number of questions on how AI could be used for differential diagnosis of infection. Can we use AI for antimicrobial resistance, which is important right now. But I guess there's one question. See, Vivek Ranjan has asked a question as to what would be the most efficient source of data in the health sector. And from all the speakers, including, I think, particularly yourself just now, Krishnan, it seems that we're actually generating a lot of data in many of the programs that we're rolling out. But is there going to be a source of data, or is it going to be more like we will have to generate our own data to make the advances in health?
The simple thing is that, like in every other sector, like if you have ERP systems in companies today, they capture the data, they look at it, and only then they're able to develop AI models.
Yeah.
If Google is able to predict on the Gmail what I'm going to write next, because it has studied billions of emails and it knows what comes next. It knows the language. So unless we feed some data for it to work on, it can't really make a prediction. And today in our country, especially in the health space, we don't have digital data. We don't have so much of it. So the first step towards anything that we do in AI is to start building digital models and build them in a way that keeps the future AI in mind. So we have to look at collecting data and collecting it at scale at a very low cost and through people on the ground. I don't know if you're able to see my screen. Are you able to see my screen?
I can. So can I ask you in just like a minute to take us through the screen? Because we have, I think, 25 minutes left for 2 demos where we had given each 20. So I'm also going to just ask Dr. Hegde and Professor Bhattacharya to be ready for your demos.
The only thing I wanted to show here is just a minute, in the sense that this is the kind of summary data around the entire health space which the government is putting out in the public domain for people to see and play around. So this only to give you an idea of the kind of granularity that actually exists below this. So this is a summary that's being presented every district wise, how many are the members registered, who are the high risk mothers, what are the kind of risks they have. If you go to the vaccinations, how many were 0-day vaccinations in each category. Okay, and if you look at the kind of deliveries that are happening, for example, if you just look at THC wise, you will know, and depending on the actual location of the delivery, for example, if there is a delivery in the PHC, 97% were 0-day, the sub-center, these were the number of 0-day vaccinations. So the kind of data richness which has been created, this is an essential prerequisite for us to start building on. So if the state has the confidence to do this and go in the public and say, this is what it is, this is the kind of data-driven kind of a health governance that we need to bring in as a necessary prerequisite to really start doing things at scale with AI. I'll stop with that.
Thank you so much, Krishnan. That was thoroughly fascinating, and particularly to see that there is this level of rich data actually in the government.
And in
the
public domain, yeah.
And in the public domain. I'm going to ask Dr. Aparna Hegde to actually take us through the presentation that we had foreshadowed earlier on. Could you take us through exactly what mMitra is and what Armman has been doing? And then, and may I request you actually to make this slightly briefer instead of 20 minutes, perhaps 10 to 15 minutes, and we've already had a discussion around some of this. Dr. Hegde, we can't hear you or see you. So if you could turn your, we can see the screen, the presentation, but can't see the video.
I had muted myself. Sorry about that.
Great.
Can you see me now? Can you see the slides now?
Yes, thank you.
Yeah, so India has really poor maternal child health indicators. We're aware of the fact that a woman dies in childbirth every 15 minutes in India. 2 newborns die every 5 minutes in India. So the numbers are some of the worst in the world. And there are 2 principal reasons for those, right? One is, on the one hand, there is lack of access to healthcare information, because in extremely overcrowded hospitals, or the ASHA workers not having the training or the time to go home to provide information means that the women are not informed and they don't access care early. And on the other hand, the health workers are not trained enough to detect and treat the risk factors and complications early, so that women and children do not die, right? So this leads to, and because of these 2 issues, you have a poor primary care system, you have weak referral system where the women are not referred in time to higher level hospitals, there's delayed care seeking, overburdening, and leads to increased maternal and child mortality and morbidity, right? So Armman leverages technology to create scalable, cost-effective solutions, because technology allows you to, on the one hand, keep costs low. So basically our pillars are that we leverage technology, the solution is scalable, cost effective, less resource intensive because our human resources are reduced because of technology being used, but we use a tech plus touch approach, as I told you earlier. And we leverage the existing health infrastructure of the government of India and partner NGOs, and we use an evidence-based approach. Right. So on the one hand, we inform women about the care to be taken during pregnancy and infancy. And on the other hand, we train health workers. So we are hoping that over time, we're able to reduce the number of high-risk referrals from the current 50% to less than 25%. And that's the hope, in a scalable manner, right? So we look at mMitra. Now mMitra, so, it came from my experience during residency where, I've sat in antenatal clinics that are completely overcrowded. So we didn't have time to even look at a patient's face, forget counseling them. And then they would come back dying. And little information access would have saved lives. So what mMitra does is, because almost every woman now has access to a family phone, if not her own phone, it's a free voice call service which sends information weekly or twice a week, literally twice a week in pregnancy and twice a week in infancy. We send voice calls directly to their phones in their chosen time slot and language preference, right? So, and these voice calls have been created by the national medical body in collaboration with the national medical bodies. So we enroll women wherever we can get them. So we have our health workers stationed in government hospitals, almost 97 hospitals, where they are part of the system. Woman for the first antenatal visit, she's enrolled her details are taken. But because women come to the hospitals too late, we also have form partnership with community NGO partners, and through their we incentivize their health workers to enroll women early in pregnancy when they go on their normal rounds in the slums of urban India, and in the rural India we have ASHA workers who enroll women for an incentive, right? So when we enroll them, we'll take their phone number, gestational age or age of the child, because the voice calls are timed and targeted. It'll give you information about the care to be taken in that particular week, prepare you for something very important in the future, and reinforce very important information from the past. We also have a time slot choice so that woman can ensure the family phone is with her, and there's a language preference. We have 5 languages, right? Now, we have 3 tries for every message. So in all, there are 141 voice calls, around 1 to 1.5 minutes long. And it's twice a week in pregnancy, once a day in the first 7 days after birth, twice a week till the child is 3 months of age, and then once a week till the child is 1 year of age. So it's like it handholds her till the child is 1 year of age. There are 3 tries for every message because we don't expect a woman to pick up more than 60% of the calls. So Monday, Tuesday, Wednesday, in the time slot that she's given, for the first message of the week, we'll send her a call. If she misses all the 3 tries, we have a missed call system. She can give a missed call to the system, and the system will call her back. We also have a call center. As I told you earlier, we do a tech plus touch approach, right? You can't just have technology sending information, right? You also have to have a live person. We have a live person in the hospital and in the slums enrolling her. At the same time, there's a call center that she can call. Like if she's delivered and she wants to switch to infancy messages, she's aborted and wants to stop the messages, she's changed her phone number, her time slot has changed, she can give a call to the call center, and the call center person will call her back. And now we are answering any query the woman may have, right? And this is a call center that we could really modify for COVID, right? And we've reached, because Amitra has reached around 2.3 million women in 5 years through 97 hospitals, 40 NGO partners in 9 states, and 8,000 Sakhis or health workers in the field. Now, because we did Amitra quite well, Government of India has entered into partnership with us, and we are managing the Kilkari program of the Government of India. Kilkari is similar to Amitra. It's a voice call service. It's working in 13 states, and it's reached across to around 18 million women. And on the other hand, I told you we train health workers, right? So we have the Mobile Academy program. I'm going to keep it brief. Mobile Academy is a mHealth based ASHA training program. Is a refresher course for them where they can call in. It's 4 hours of content, and it's 11 chapters and 4 sections in each chapters and a quiz along with that. And now we are actually going to go on to Mobile Academy 2.0, where we can use smartphones because the ASHA workers, 30% of them have access to smartphones. So we're going to go on to more 2-way communication, WhatsApp communication, multimedia approaches, etc., so that we can actually scale it through the country, right? Now, Kilkari and Mobile Academy currently work in 13 states of North and Northeast India. And right now it's 18.8 million women and 160,000 health workers. By 2025, we hope to scale through the country. There are 45 million women and 1 million health workers is the goal. Now, where does AI come in, right? And we have a wonderful partnership going on with Google. Because of Kilkari reaching across to almost 18 million women and Amitra 2.3 million women, and the Mobile Academy program is almost, it's going to reach 1 million health workers. We can use AI on the big data to really help us improve our programs. So I'm going to give you one example that's really working for us. Now, Amitra has a dashboard, and I'm not going to go through the dashboard at length, but one thing that we really look at is listenership, right? So you send the voice call, technology has to work, and the women have to pick up the calls, engage with it, and then listen, right? So what we found is that women, only 50% of women listen to more than 70% of the content. Now, there are various reasons for it, right? They may not have the phone at that particular point in time, they may not have given the right time slot, or there may be other issues that's going on, right? So how do we pick up those women that have got low listenership, right? And then ensure that they come back into the program? Because honestly, the systems are so overloaded, you will need technology to be able to reach maximum number of women. So we can pick up those women who have got low listenership, and we can design programs that have more targeted approaching to them, right? Or more hand-holding of those women. We'll be able to cover all women. So we have a partnership with Google and IIT Madras and Milind Tambe from Harvard, where what we do is, this is an example of improving listenership. So we're using AI to kind of understand in real time how many women likely to drop out of the program and how to bring them back, right? So how are we doing it, right? So step 1 is basically we've analyzed data to identify engagement patterns based on demographic data and call logs, right? And based on the analysis, we've understood that if a woman has not heard more than 30 seconds of media on more than 50% of calls, we call that low listenership, right? So these are the women who are at risk of dropping off. right? So if they're listening less than 30 seconds of media on more than 50% of calls, they're high risk. So Google has developed two models, where a short-term model and a long-term model, right, based upon beneficiary data and listenership data. So the short-term model is based upon 4 weeks of data, and then we are able to predict likelihood of the beneficiary engaging for the next 2 weeks. And then long-term data takes up data for 2 months, and then can predict for the next her life cycle, right? So then we did a first pilot study where based on long-term data with the best prediction recall trade-off, we used it to predict for beneficiaries who were enrolled in November 2019. So this is a kind of graphical picture of it. So training data, so around 10 months of data of 3 lakh women was used. Around 70 lakh calls were analyzed, right? And the features that I looked at were, her static features like her gestational age of the child, education, phone ownership, call slot, income bracket, gravidity, parity, and a lot of other parameters which are distinctive for the woman. And then the call features, right? The call status, duration, month of call, gestation of the call, and so all of these data were taken, and then the prediction engine was created, right? And then we applied it to the November data. 18,000 women it was applied to, and what we found was that we used a prediction engine to pick up who were low risk women who are likely to hear the calls and not drop out, and then the high risk women. So we picked up 6,499 who were potentially high risk women, right? And so the prediction model or the machine learning was done for around almost 8 months of call data, right? So the first 60 days were used to generate call features, and the next period was actually used to generate labels, right? So basically, how does the machine learn what is a good listener and who's a bad listener, right? And then use that to predict. So then we had these algorithms to understand low risk and high risk, right? And out of multiple models created, the one model, which is Randeep, which was the best performing model because it had a good trade-off of precision recall. Initially, we went in for high recall, but that was picking up too many women, right? So we at that phase where we picking up the right trade-off between precision and recall. And Google has built this dashboard for us. So this dashboard is an ongoing dashboard where we can actually pick up the beneficiaries who are at high risk of dropping off from the Mitra program. And then, what we've done is that the first cohort we've worked with. So the first cohort is a group of women who were enrolled in November 2019. That is 18,766 women. And then we kind of, the model which is created and which predicted the low listeners was actually validated using on-ground values, right? So because we also had that call listenership, right, till April 2020. So using live data, we validated the model, right? And also what we did was, because this is a pandemic time, they separately analyzed pre-pandemic behavior to ensure the results are independent of any behavioral changes because of the pandemic. Now, and what we've done doing now is that we've done an RCT, right? We're doing an RCT where of the women who are likely to drop off, they have been divided into 3 groups: Group A, Group B, and Group C. So, I mean, if 6,000 women are the women from that 2-month period who are likely to drop off. So first group, that is Group A, were sent calls, right? So we actually called, our call center executives called these women who are likely to drop off, and got feedback from them, understood whether any changes had to be made in the program for them. For example, their call slot has the last menstrual period be taken properly, language preference is correct, right? So all those data was taken, and we really implored them to join back the program. Group B was sent an SMS, right? So is an SMS enough to get them back in? And Group C, there was no intervention. I'm just finishing last couple of slides. And so, it really showed, this first cohort, a very small study where we had this 3 randomized Group A, Group B, Group C with 2,000 women approximately, right? If you see the number of women in the 3 groups. And if you see the call intervention group, right? All of these are poor listeners, right? So if you look at the intervention group, which received calls from our call center, look at this, right? 49.5% engaged among all the answered calls. 49.5% engaged. So that means that 49% of women who picked up the call actually listened for more than 30 seconds, as opposed to 35% in the control group, right? And SMS did not work as well. So, I mean, these are low listeners. These are women who are anyway dropped off. If you're getting back 50%, that's great, right? And if you look at number of women who out of scheduled calls picked up, again 33%. So they've answered the call, it's gone properly. 33% of them actually listened to more than 30 seconds of the call, right? And that's much better than 11%. So we are able to get these women back. So our whole hope is that we will create a pyramidal structure, right? So if we can get women back to listen, there might be a whole lot of women who may never come back. Maybe technology is not the right way to get across to them. At least we're able to pick up those women and we're able to create other programs for them. So we are hoping to create a pyramidal structure where we have Mitra or Kilkari for the larger group of women who are listening, and more targeted programming for those who are never going to access technology-based programs, right? So a paper has been published on this work that we've done with Google. And going forward, we want to be able to kind of pilot in Mitra further. We want to be able to kind of, correlate, this model with health outcomes. So what if we apply this model in Mitra and then look at health outcomes 2 years later? Like applying this model, are we able to get back more number of women into the system? And is that leading to, better behavioral change or health, outcome going forward? That's what we want to do, and then implement throughout Mitra. And this will then get scaled up through Kilkari, because through the partnership that we have with the Government of India, and that's 30 lakh women, right? At one time, 3 million women are getting Kilkari. So you can imagine how many women we can help by using this one model. And last slide. Yeah. So the last thing is, look at the amount of things that we can do, right? Get women back into the program through Kilkari, right? Content optimization. We're talking about voice calls. There may be women who may be from different demographic profiles who may need different nuanced. The kind of content that they may listen to may need to be graded, maybe stratified, right? So somebody who is very underprivileged may only need simple information, right? Whereas you might have women from urban India who are slightly more educated, who might be able to hear more complex content. So hopefully we can use AI to do content optimization. For Mobile Academy, that is ASHA training program, we are hoping that we can do not only content optimization, but also improved listenership for ASHA workers. Lastly, high-risk prediction, right, for both mothers and children. Malnutrition is a very important issue, because if we can predict children who are likely to get severe acute malnutrition based on their parameters on the ground, right, we'll be able to save multiple lives. And lastly, we're hoping for convergence, right? So we can converge our health worker data with our beneficiary data and create targeted programming through AI. That's where we are going with this. Thank you.
Thank you, Dr. Hegde. Mitra is fascinating, particularly the numbers that you're talking about. We are sort of running out of time, so I don't want to take more time away from Professor Chiranjeev Bhattacharya. Professor Bhattacharya is a professor in the Department of Computer Science and Automation at the Indian Institute of Science. Obviously, it's a preeminent institution in the country for data science and machine learning. And he is going to do a presentation on the use of drones for disadvantaged groups. Professor Bhattacharya, if I can request you to share your screen and start your presentation.
So thank you. It was a fascinating discussion. I was listening, but I think you have the option now of not allowing me the presentation and ask the panelists some interesting questions.
No. I mean, absolutely. Please make the presentation. I'm a drone enthusiast, so I'm very interested to figure out what you have.
Okay, never mind. So what I'll do is, since there's not much time, I will, and I know it's quite a long session. So I will request my Digital India colleagues to play a video. And after that, if you have interest, I can explain a few things around that video. I had a presentation first, but I would rather go with the video.
Sounds good. I will stop my video so everyone can see.
Right.
How are you? I?
Fine.
Very good.
Hi. What is your name? What is your name?
Lightning and thunder is seen when it rains. We make paper boats and play. We carry umbrella and we wear raincoat when it is raining. From floods when it is raining heavily. You did it. My name is Krishnan. What is your name?
My name is
I am 5 years old. How old are you?
I'm 16 years old.
Is a 16-year-old verbal child. His responses to questions based on lesson or about himself was always in short phrases. After introduction of Cosmo in his lessons, he is able to answer in long sentences. His interest in Cosmo has helped him progress at a faster rate. she never liked to do exercises. Also, her very slow movements, in spite of the teacher assisting her, took a lot of time in the gross motor sessions. We observed that when we paired her sessions with the drone, her interest in exercises improved, which was a great relief to the teacher because she showed a lot more interest.
Since he's very much interested about electronic gadgets and all, drone motivated him a lot in doing exercises, and his attention level has increased a lot, even the focus. So it's like for him, like it's kind of a wonder thing for him that he has got a drone. Because of this, he's very happy and he's following the drone instructions, everything, and now he's doing exercises with the drone, not without. I mean, without drone, he's not at all ready to.
Yeah, so that's all I had to. That was the presentation you saw. So actually, what we wanted to say is that there's a theme called socially assistive robots. So often when a robot means autonomous cars, robot means picking some things and doing some things. But there is a new area, I mean, at least new to me, and I think globally also is new, which can, I think, revolutionize the way we treat, especially elderly, treat especially children. All these children you see, what is so special about the children running, but autistic children has a serious problem. And these are all not normal children. And so because you have to blur the faces, I mean, what gave me the maximum satisfaction was the children was doing smiling. So that I will cherish. Anyway, so I had a presentation on socially assistive robotics, but I think I made my point.
No, you did. That was extremely powerful and actually very moving as well, because when you see the children in the before and the after, it really shows. We sort of tend to think that technology is very cut and dry, but actually technology can be pretty emotional as well. So that seemed like a fabulous demonstration. May I ask just one question? We are completely out of time, but I can't help ask, what are the other uses for which this can be put, just in terms of this disadvantaged section of society? We've seen sort of motor skills, we've seen some social skills as well. So what are the limits of this technology? Where do you see this going?
Okay, so I'll not call it limits of technology, but I would like to frame the question in a way so that what can you do with this? This is a small demonstration, right? So I believe that this is a thesis I'm working with hospitals and all that. It's taking time. So there is a large section of population which is affected by what is known as neurodevelopmental disorder. Autism is one of them. Mm-hmm. Often what happens is, suppose you suffer a neural paralytic stroke. So I'm sure some unfortunate incidents may have happened in some of our homes. So you will see elderly people, they can't remember things. They can barely walk after a stroke, right? So these kind of things will severely help. Dementia, just to name a few, right? So neurodevelopmental disorder is one of the things which has struck my, how should I say, my interest. And I think for sure that is one area it is going to be very important. Also, it severely helps improve in learning outcomes for very small children. See, one of the outcomes was that the child refused to speak in English. After some time, the child is automatically speaking in English, like answering in English, not speaking. Maybe that's too much I said. It's answering in English. So you see, the side benefits keep coming. So I think it, in an ideal place, I mean, I am now convinced that if I had the resources and all that, I can prove to you a new classroom where these things will come and go, and you will see the children outcome severely increasing. Anyway, I'm not sure. At this point, I'm in a ecstatic part of the curve. Very soon I'll come down and say, oh no, this doesn't work. But anyway,
thank you so much, Professor Bhattacharya, and also thank you to all the participants of this session, Anil Bhansali, Tavpritesh Sethi, Randeep Singh, Manish Gupta, Dr. Aparna Hegde, Krishnan Dharmarajan, and Professor Bhattacharya. This has been much more than I expected, and we ended on an emotional high. Thank you all for all the work that you're doing. And this is just proof that, we don't need to read about this in international journals. It's all happening in India. Thank you all. Stay safe and enjoy the rest of the program.
Thank you.
Thank you. Thank you. Thank you for inviting me.